I'm doing my presentation on ostomy care. Originally, I was going to do it with a cut-to-fit barrier for the teaching, but I couldn't get a hold of those as it's very expensive, and I didn't want to buy the whole pack because it's $45 to about $120 depending on the packs, and they only come in 5 to 10s. They wouldn't let me get just 2. So, why is an ostomy needed? So diseases such as cancer of the bowel or diverticulitis, when there's outpocketings where they perforate, they'll take some of the colon out, and then sometimes it results in having to have an ostomy, or if you have a disease such as Crohn's or colitis and it's very severe. Neurological issues, so if you have trauma, if you don't have the capacity to be continent of your bowels, sometimes that is a solution. So basic information. The output is called the effluent, and the consistency will vary. What we're doing today is the colostomy, and it is going to be softened or formed. In between, it varies a little bit depending on exactly where it is in the bowel. They can be temporary or permanent. It depends on the type of surgery that is performed. And the pouching systems available today, they have special adhesives on them that are heat and pressure sensitive. So if you're putting it on, you want to put some pressure on there for a couple minutes just to help it adhere, or maybe you can get the patient to if they're capable. And it shouldn't be changed every day. It only needs to be changed every 3 to 7 days. If you're changing it too frequently, this can create some irritation on the skin, and it can also create some trauma to the skin where it can create skin tears or blisters or a rash. An exception is if it's leaking. You want to change it regardless of when you put it on, because the effluent that leaks underneath can actually create more damage. If it continues to be a consistent issue, the leaking, then it's an indication that a different system is needed. They must be emptied when they are a third to halfway full, because if it's too full, it's a lot of weight and it'll pull on it, and the barrier won't be as effective. So again, speaking about cost, it's really expensive. If the individual is paying for it, it's very important that you apply it. Well, it's important regardless of who's paying for it, that you apply it correctly, because they are very expensive. One wafer, if you mess up and you have to replace it, then that's like $15 per wafer. Depending on the brand, again, it's 40 to 120, and again, it only comes in about a pack of 5 to 10, depending on the brand. When communicating with the clients, you're going to want to make sure that you avoid anything that can be seen as disgust, so either verbally or physically, like you don't want to grimace or anything like that, because you're going to hurt their feelings. They're probably sensitive about that. That's not something people really want to talk about. I was talking to the one lady, and she said that her grandkids didn't even know for years and years and years that she had one, because she just didn't want to talk about it. She was embarrassed about it, and again, you have to be very careful, because you don't want them to be self-conscious about it, even though they probably are. When you're assessing the stoma, you want to assess for color, and you want to assess for moisture. It should be pink or red, and it should be moist. You want to assess the size. If it was newly created, it can change in size from about 4 to 6 weeks post-surgery. And you have to measure each time when doing this, because a different pouching system may need to be used depending on how much it changes. And you want to assess the type. So it can be a budded stoma, or it can be flush, or it can be retracted. So these are some pictures. On the top, those are typical normal ones. You can see some scarring here, and that's normal because it's not excoriated, it's not at risk, it's perfectly fine. And then the bottom ones there, you can see some blistering there, and there's a little bit of skin sloping off there. So that's a little bit of necrotic tissue. And then there's a prolapse one here. I know you can't see it very well, but there's some blistering and some keloids. Keloids are fairly normal. Again, there's a bigger picture there, a different view of the same one. And then this one is necrotic tissue. As you can tell, it's got some black and kind of some purple spots on it. So those are abnormal ones at the bottom. So you want to assess the peristomal skin. Is it intact? Is it red but intact? Is it raw, or their blisters or a rash? Sometimes people can have a rash because of allergic reaction to the adhesive. I know that if I have like tape or something on it, if I take it off, medical tape, I always have a rash underneath, even Band-Aids. Sometimes when you're changing it frequently, it can pull some skin off and it can make it red and irritated. So again, there's some pictures of abnormal peristomal skin there. What type of effluent? We were talking about that earlier. Colostomy, what we are focusing on today, what we'll be practicing, it'll be softer formed. And ileostomy will be liquid. And ileoconduit will be mucus with urine because it goes through a part of the intestinal segment. Unexpected outcomes. So you take the wafer off, and maybe the stoma looks fine, but when you take the wafer off, you find a reaction or a fungus or skin breakdown. What would you do?
Like report it, and then just exactly what it says, remove the pouch carefully, ask patients if they feel any pain at all.
If there's something wrong with the stoma itself, if there's blistering on the stoma, do you think that they can feel that?
I don't think so.
There's not a lot of nerve endings there. They can feel the outside, but generally they can't feel when there's a problem. That you have to visibly see it to know. So you would remove pouch carefully, change pouch more frequently. You would want to probably get a better fitting pouch if that's the case, because it's probably a reoccurring problem if there's already some skin breakdown. And you want to consult an ostomy care nurse. Another expected outcome is, again, when necrotic tissue is found. I showed you the picture of the one stoma that was kind of purple and black. Sometimes they're dry instead of moist, and if you rub them, they don't bleed because it's dead tissue. Again, tissue sloughing, and you would report to an ostomy nurse or a nurse in charge or a doctor. You document date, time, and the appearance of the stoma. That's important because if you don't report it and somebody else comes in and they see it and it's getting worse, then you're going to get in trouble. The next unexpected outcome is if the client refuses to look at the stoma. That would be some shame and embarrassment resulting in the stoma. It's not something people want to really have. You would want to obtain a referral for an ostomy care nurse. Allow the client to express their feelings, and that's very important. And you want to encourage family support. If you don't have the support, it's going to be if you're already having a hard time with it, it's going to be difficult if you don't have some support. Delegation. Pouching of a new ostomy can't be done by nursing assistant personnel. Some agencies allow pouching of the nursing assistant personnel once it's established, so that's 4 to 6 weeks post-surgery. and that's once it's healed properly and it's not really changing. The nurse delegating will direct the MAP of expected color and drainage and amount. They will tell you of the expected stoma appearance, the equipment needed, and as well as to report any changes to them. So equipment. You're going to want to have your skin barrier. And today I have a 2-piece system here. Actually 3-piece because I have a clip. So I was going to have the cut to fit one, but this one is actually a flexible one so that you can mold it kind of to fit the stoma. And then I have the bag, and really you would want to have a clear front so that you can see the stoma, so it's visible, and so you can see how much of the effluent is in there and how much gas is in there. And normally, like with some of the newer ones, they have like kind of the Velcro integrated, so you can just fold it up. You don't have to worry about fumbling with the clip. So there is ostomy measuring guides, but for reasons of like being sterile, I wouldn't really want to be using that. Like I'd want to throw it out after, because you can't put it on one person's stoma and then, like even if you clean it, you're not maybe going to get it all. So maybe like a ruler or something. And you're going to want clean gloves, a washcloth, towel or disposable waterproof barrier so that you don't get it on the clothes or anything if it decides to come out while you're cleaning it. And your basin with warm tap water and scissors, which we won't need today because I have a different one than expected. So implementation. Position the clients in a semi-reclining position. So you want to do this because application is easier when they're in that position. If they're standing, sometimes it would obviously be hard because they'll be moving, maybe they're not steady. If they're sitting, they're going to be crunched up and their skin's going to be wrinkled. So you're going to want to perform hand hygiene first off, and then you're going to want to apply clean gloves. So again, what we were talking about, we reduce the spread of microorganisms. So you place a towel across the client's lower abdomen. It protects their clothes and their bed sheets. And you will remove the skin barrier and pouch that is already on there by gently pushing the skin away as you're pulling it off. That will reduce skin trauma, and proper removal causes peristomal skin irritation. So next, you will gently clean the peristomal skin. You don't want to scrub because that'll, again, cause skin breakdown. You don't want to use soap because that can leave a residue and the adhesive won't stick very well to it. And you want to pat it dry instead of rubbing it dry, and you want to make sure that it is dry because it doesn't adhere well to moisture either. You want to measure the stoma. So you want a proper fit. If it's too tight, you're going to be kind of choking it, and then there'll be some rubbing. And if it's too loose, then you're going to have it on the peristomal skin. You want to if you have the cut to fit, you're going to trace the pattern on it so that when you're cutting, it's accurate. So again, if you had the cut open, you would cut it open and then attach the pouch to the skin barrier. With the ones that you can see through, I would attach the pouch on first just so that you can see the stoma. That's just through some practice that I've done, and with those ones, it's a little harder. You can put it on before, but I would put it on after just so that you can see the stoma when you're applying the wafer. It is kind of hard though to apply it after because then you're pressing on their skin. So then you would close the end of the pouch, and then you would dispose of the pouch, the old pouch that was used, because you want to get rid of it immediately because you don't want there to be a smell in the room because that could be embarrassing for them. And
Would you
then,
empty into the toilet first?
what's that?
Empty into the toilet first?
If there's one close by. And then you would remove your gloves and perform your hand hygiene. So recording and reporting. You'd want to take note of the type of pouch and the skin barrier that was used. And you're going to take down the amount and appearance of the effluent so that you know if there's any changes. Size and appearance of stoma, again, for any changes. Condition of peristoma skin, level of client, family participation. If they're not showing any interest in it or they're not assisting at all. If they're supposed to be going home, it's going to be very hard for them to do self-care if they're not practicing or they're not paying attention to what you're doing. You want to write down any teaching that was done and the response and report any abnormal appearances. So there's references. And so demonstration. So I've got my little made up stoma here on my fake skin. So you put them in a semi-reclining position, perform hand hygiene, put on your gloves. So this stoma, it's about 2.5 centimeters. And this opening here is just a little bit smaller than that. You want to obviously cover them up. So I'm just going to open that up a little bit. Place it on. So you're going to want to kind of press down on the edges all the way around, especially the edges here and in the center, because if the edges aren't pressed down, then they're going to end up curling up and they'll just keep pulling up because they won't be sticking anymore because you'll get residue on it from clothing or lids. You want to make sure that it's clipped all the way around. Touch there. Okay. So I'll get someone to redo this here. Can I have a volunteer? Let me get rid of this.
Okay,
stuff here.
wash my hand while you're doing that.
Okay,
Can you take this off?
so what would you do first?
Wash my hands, assess the patient, hey, how's it going? Or assess the bag, see how full it is, okay. Did you want me to take this off?
Yeah, what would you do to take it off?
I don't know, you can go through that.
Pull it down.
Oh, the whole thing, right?
Yeah.
I was on where you're there.
Sorry, I was a little bit.
Okay.
So I'm gonna push against their skin,
Yeah.
right, so it doesn't get that good.
And what position would the client be in?
Semi-reclining. Just gonna twist the patient all around here. Okay, so now I would put this on. I'd be assessing the stoma. And look, see if there's any necrotic tissue. You don't want to see any of that. See that it's moist. For any tissue damage. Okay, I would clean the area. Measure. 2.5 centimeters. Crack this guy open.
And what would you do if during opening everything and setting things up, if it started to leak?
Probably throw a towel over it.
No.
No.
Here you go, just put this towel on. Okay, so you do have the towel underneath to protect the bedding, right? So you would just
I heard that from somewhere.
get a new cloth. You would get a new cloth
Okay.
and you would clean it again
Okay.
and then dry it. Would you rub it?
I would. I would do.
Perfect.
Okay. So I'm gonna measure this guy. I heard that from somewhere. That's all. So this is about 2 centimeters. So I'm gonna crack it. How did you do that?
You have to take off this, I know this one's a little different.
Okay.
They were samples, so that's what I got instead of breaking the bank to.
Just measure again just to be sure.
And this one's like perfectly symmetrically round, but of course you're not going to see that all the time. It's
Okay.
going to be very rare.
So I'm gonna put it over. Is that fitting nicely there? And then I'm going to remove the backing, making sure that it is flush on there, so there's no residue that gets underneath. So that can cause it to not adhere properly. This around. There we go. Right, then I would attach my bag. Probably close it first. Does it matter if I close it first or afterwards?
Not really. Like if it's really leaking, then I would probably close it beforehand.
Okay, closed. Oh, no, not closed. There. Something like this, so positions like that. I'm going to attach this down here. Make sure it's nice and snug. Oh, I wouldn't do that. There. Push it on the sides.
Oh, that poor patient.
And that fits pretty good. Make sure it's
Are all the
closed.
edges down? Is it all? You should get them to hold it for how long?
Oh, what messed that part? I'm sorry.
Couple minutes?
Couple minutes, yes.
To help it adhere
Adhere
properly?
properly.
Because it adheres with heat, yeah.
Heat.
It's sensitive to body heat.
Okay,
Okay.
good. That was good.
So in one of the demonstrations that I was watching online, they actually had taken off this backing first around the outside. Like they took off this one and then they took off this one as well. I've done a lot of these and I just found that I messed up less if I was to take off that first, then apply it, and then kind of slowly like spread the top part and then kind of just go around, because I find that it gets a better seal and I screw up less because you really don't want to screw up because these are very expensive. Okay, are there any questions?
Should we check for like the patency of the bag? Like I don't know,
Yeah, and when do you?
What, sorry?
like the patency, like so there's no holes in it, like before you apply it? Like,
Yeah, but normally like they come in a box and they're generally
And then like you're
perfect shape,
talking
but yeah,
about
you should check
discharge
because they
and
don't
stuff
want it to leak.
in the bag. So when you're emptying that, would you like do Cambrian amount?
for weight?
Yep, that was,
Or how do you empty the bag and?
well, you take the clip off and then you'd have like a little, like a a pad or something, and then you put it in and measure the amount and look at the consistency. A lot of times they don't ask you to look at the consistency and the amount. You just kind of empty it or you throw out the bag. That's in my experience anyway. But you should, just so you know if there's any differences, because that can tell you a lot of what's going on with the patient if there's something else wrong with them. And again, you want to have a clear one so you can see it. And so you can see the stoma, and so you can see the effluent. Any other questions?
Have you ever heard of people poking little tiny holes in it so that the air comes out?
No, but if there is a lot of air, if they are producing a lot of air, either you can change your diet, because that has a lot to do with it, or there is the little carbon filters that allow the air out, but don't let any liquid out at all. It's a really nice new thing that they have now. Not everybody has them. They are, again, a little bit more expensive. So again, because they are expensive, you're going to want to be able to rinse the bag out and reuse it and try to clean it up. And
In second year, they teach you to burp them?
yeah, yeah. And that's easy. You just take the clip off, and you want to keep it up again. So it's
I think
not
that's
easy.
kind of like
No, I've
Okay.
actually heard of people actually taking like a pin and physically poking little holes in the top of the bag.
What happens when you're laying down and sleeping?
Well, that's my thing, right? That's what they would do, is at the very, very top here, they'd poke little holes, just enough for the air to get out, small holes. And I think it's more of like kind of a cost-cutting measure. It's in like a nursing home so that they don't have to constantly go to the person's house and, burp the bag.
Yeah,
They do that so
especially
that
for
everything is kind of escape.
Especially for someone who isn't able, like cognitively there, you're gonna wanna make sure that you're burping it and checking it consistently, because you don't want it to break open, or if it's too full and it starts bubbling up and everything, then the pressure can make it go in behind. And now you guys have a post quiz that's underneath that I told you to leave flipped over. Okay, and that's everything.